I don't think this would ever happen in real life. Just not a chance. Hi, I'm Dr. Jeff Yu, a board-certified ER doctor in the USA and Canada, and it's 7 p.m. shift change in the Pitt. Today I'm going to be watching the Pitt Season 2, Episode 13, and I'll go over what's realistic, what's not, and I'll explain all of the medical management throughout the show. Let's get to it.
Orlando Diaz, we were treating him for DKA when he eloped.
How far did he fall?
20 feet or so. He left against medical advice. Lungs are up bilaterally.
Pelvis is stable, right tip fib hematoma.
Basal skull fracture.
We've got a diabetic patient, 20-foot fall.
The Cushing's reflex. From increased intracranial pressure.
So they're starting this episode off with the DKA patient that left against medical advice because he didn't have medical insurance and couldn't pay out of pocket. The Cushing's reflex is a triad of 3 different things that happen when the pressure inside of your brain is too high, either from edema or from bleeding. So the 3 things that happen are 1, your blood pressure spikes up, 2, your heart rate drops down, and 3, your breathing or your respirations become more irregular. This is a pretty late finding, and if someone already has signs of a Cushing's reflex, their chance of survival is really, really low. The typical things that we would do in this scenario are 1, we would start to hyperventilate the patient because this can actually shift the amount of carbon dioxide and acidity in your blood, which decreases the pressure. 2, we would push either one or the other or a combination of hypertonic saline and mannitol, which is essentially sugary fluid. And all these things will act to decrease the pressure inside the brain. The other thing that we would also do is we would actually angle the bed up at 45 degrees so that the fluids from the brain drain out with gravity.
The DKA is resolving.
So what made him pass out? It's hot as hell out there. He could have been dehydrated from sweating, or he could have had an NSTEMI or a posterior CVA.
In someone that was just discharged from hospital for diabetic ketoacidosis, apart from the actual metabolic derangements, there are many other things that could cause someone to faint, especially in a situation where it's incredibly hot outside and he's standing, walking around in heat. This is something that we see very commonly. Another thing with diabetic ketoacidosis is that you can become very dehydrated. Dehydration can obviously lead to fainting episodes.
All right.
All right, so the computer systems are back on.
Yeah, not so fast. Every chart from the last 5 hours needs to be scanned into the electronic health record and checked for accuracy.
So this actually isn't accurate. When we have downtime, what happens is we put all of the physical bins in a chart, and then all the charts would actually be taken to health records, and health records would then take those charts and scan them and put them into the patient's file. That wouldn't be the responsibility of the actual healthcare workers that were on shift.
Mr. Haas, pulmonary edema after missed dialysis, now stable with the son Mason at the bedside.
South 21 next.
Mr. Digby.
It's just Digby.
I can take him.
Sold to Dr. Tamarian. Moving right along.
This is quite realistic of them walking through the emergency department as a team and going face to face and talking about the patients in front of them, explaining what their diagnosis is and what their treatment plan is, especially during an IT downtime where there's no ability to actually look at their electronic medical record and all their investigations. When I was going through medical school, this is before the advent of electronic medical records, we actually did this every shift change. We would walk through as a group, look at the patients, talk about them, and then move on.
Hey, Carrie. You were on scene with Orlando, right? Did you notice anything about his fall?
Too busy working on the guy. IV, intubation, backboard, splint.
Thanks.
In real life, I see the same paramedics day in and day out. So, it's quite common for me to know their names, shoot the shit with them, joke around with them when they're bringing patients in. Paramedics really do feel like a part of the team.
Brady Barnhill wheezing and not responding to albuterol. Pulse ox 87 is Mother Naomi.
Fusing all his accessory muscles.
This patient's being brought in with a severe asthma attack. Things that would point us towards respiratory distress or really bad work of breathing is scaling retractions. So these muscles over here start to retract and become more visible. When you're breathing, you can actually see the outline of the ribs when you're kind of breathing in and out. Above your sternum or your breastbone, you'll actually see your throat actually being sucked in during every breath. And the other thing is substernal retractions. Your entire belly is sucking air in and out. This happens because you have so much air hunger that all of the other muscles around your body are working really hard to actually get extra oxygen into your body. It's a sign that you have impending respiratory failure and possible requiring intubation or you're about to die. These are all indications that you have to medically manage the person very aggressively to turn them around before you get to that point.
Continuous nebs, 20 milligrams an hour.
The at-home nebulizer, I've been giving him albuterol every hour.
With severe asthma like this, there are a few things that we would do. First thing that we would do is nebulization of both albuterol and ipratropium bromide. These are two different medications that actually open up the small bronchioles in your lungs. We would give them some kind of steroid, either prednisone, which is an oral pill, but in someone that's breathing this hard, we would actually give them methylprednisolone, which is an IV medication that works quite quickly. In severe asthma, most people think that it's just constriction of the small airways, but it's actually a combination of three different things. So it's constriction of the airways, it's inflammation in your lungs, and it's mucus production. So essentially the medications that we give to patients in severe asthma target all those three different things. If there's any concern that the asthma might be triggered by anaphylaxis or allergies, we would also give intramuscular epinephrine or an epinephrine infusion.
Does he take any other medications? Just the albuterol. He used to be on Montelukast and Symbicort.
Why did you stop that?
Because he lost his Medicaid.
EpiPen?
On it.
0.3 milligrams.
Yeah, so they're doing the EpiPen, 0.3 milligrams in the thigh.
Shot in the thigh.
Typically, if we were giving epinephrine intramuscularly, we would do 2 or 3 jabs of an EpiPen. And if that doesn't work, we would progress to the epinephrine infusion.
Hi, Mrs. Davis. Your labs show a lot of inflammation in your liver. So I am so nauseated. Have you noticed a change in your skin coloration? I've been using this bronzing cream.
This new patient is coming in with what looks to be painless jaundice, where she has yellowing of the skin and yellowing of the eyes, which we refer to as scleral icterus. This is usually an ominous sign that the patient may have a pancreatic head mass that's actually blocking the bile drainage from the liver. Usually when someone comes in with painless jaundice, it's very concerning for an end-stage malignancy.
Do you remember the name of the bronzer? Why would my liver be inflamed? It's 100% natural.
Another possibility for painless jaundice is if someone is taking natural herbal supplements, it can actually cause damage to your liver or hepatitis. One of the common misconceptions in the general public is that natural means healthy, but a lot of people don't actually understand that natural herbal remedies can actually have really bad adverse effects on our body. I remember when I was going through medical school, there was one of these MLM companies that was selling herbal medications. This led to a case series of patients having liver failure and hepatitis. If you are going to use natural or herbal supplements, make sure that you check in with your doctor first, especially if you're on other medications. It can actually change the way that your liver processes pharmaceutical medications that you're on.
So you should think about signing out and hitting the road.
Yeah, maybe you should too. Oh, that's right. You sent Lena home. Oh, so you get to go the extra mile and the rest of us just get accused of being martyrs.
Passive aggressive. I grew up in middle class Ontario, and I'm from like a Korean background, and I'm not sure if you know, but Korean people are known for being quite direct. Koreans are kind of thought to be the Italian version of Asians, where you just speak your mind and, you know, people need to deal with the consequences. So when I entered the medical field and was starting to work in the hospital, to see so many people being passive aggressive and not actually speaking their mind was something that I really had to adjust to. If you just speak your mind and say things directly, it can be seen as being unprofessional, but I personally think that passive aggression is not a constructive way to communicate with other people.
That's our borderline, 87.
How about BiPAP, 10 over 5?
All right, Grady, shot number 2.
Might as well throw in some magnesium, 50 per kilo.
I'm sorry, he's not ventilating. We should be ready to intubate.
They're also giving him magnesium sulfate. Typically, we would give 2 grams IV, and that helps also bronchodilate the patient. They've just given him his second dose of EpiPen, and they're about to start BiPAP. So BiPAP is positive pressure ventilation, where you don't actually have to intubate them. In line with BiPAP, we would actually nebulize these inhalers so that the patient is helping to breathe. BiPAP is one of the best things that you can do for someone that is in status asthmaticus. It's actually proven to actually turn patients around and prevent them needing intubation, because if someone in status asthmaticus requires intubation, their chance of death is incredibly high. Also, their chance of going into cardiac arrest during the intubation is very, very high. We ran a very similar case in a simulated resuscitation on my channel just last week of a 12-year-old boy that came in with anaphylaxis and status asthmaticus, which was based on a real case that happened in real life of a 15-year-old boy who didn't get his airway managed quickly enough, and he ultimately died of anoxic brain injury. We go over all the management of both anaphylaxis and status asthmaticus in that case. And if you're interested, you should check out the video.
I'm sorry, he's not ventilating. We should be ready to intubate.
With an asthma patient, there's a high risk of cardiac arrest.
Yeah.
Naomi, has he ever been put on a breathing machine before?
Let's talk about this really briefly. So the reason that we try our very best not to intubate a patient with severe asthma, as I mentioned, they're at very high risk of dying from a cardiac arrest during the intubation. And the reason for that is because their CO2 is so high because they're trapping all that gas, they can't expire. Because their CO2 in their blood is high, it causes severe acidosis. And if you all of a sudden take away their drive to breathe by paralyzing them or giving them a sedative, then the CO2 actually climbs even higher, their acidosis gets worse, and that actually causes the cardiac arrest. One thing that we're trained on in residency is that using a laryngoscope gives you a license to kill. We try our very, very best to turn the patient around with all those other medications and the BiPAP machine before actually pulling the trigger to put them on a ventilator.
You're doing really good.
Thank you.
This case where they're showing Emma giving the patient like the full luxury treatment of this unhoused person by shaving him down during this like code orange situation is not very realistic. It's all hands on deck and you're really short on beds. We would reserve those beds and reserve our attention and mental bandwidth for patients that are medically really, really sick. This typically wouldn't happen in a real ER, at least not the ones that I've worked in.
Saw the scans, this guy needs an EVD.
External ventricular drain to take down the pressure.
Because CPP equals MAP minus ICP.
They want to insert an EVD or an extraventricular drain. So typically how we would do that is we would do a burr hole inside the brain and then sink a drain, guide a drain into the ventricle to allow some of the cerebrospinal fluid to actually continue draining out. And this would decrease the pressure inside the brain. This would typically only be done by a neurosurgeon in the operating room. This is not something that we would do in the ER.
Cerebral perfusion pressure in the brain equals mean arterial blood pressure minus the pressure in the skull.
ICP less than 22 predicts survival and favorable outcome. Can somebody assist?
Dr. Mohan.
Oh, don't tell me they're burr holing the guy in the ER.
I don't think so.
I've heard of burr holes being done in rural ERs where the patient is herniating and about to die. Typically in an academic center, which this is, they would just rush the patient to the operating room. They would actually remove a flap of the scalp and then do the burr hole there and sink the EVD, or just like remove a flap of the skull to actually allow the brain to swell out. So this is, I think, a little bit dramatic for the TV show. Another thing that they're showing right now is that Samira is like totally choking under the pressure. You know, if I was a resident and a neurosurgeon was doing a burr hole in the ER and sinking an EVD, I would be all over that. I would definitely want to be hands-on and kind of getting that experience because it's definitely something that rarely happens in an ER.
Masks all around, 2 sterile gowns. We brought the surgical towels, just need some betadine.
It's kind of an amazing opportunity.
I'm exhausted.
The chief of neurosurgery is here. She's kind of a legend. Do it. Giovanni will assist.
Excellent.
Jeez. Wow. Robbie is really putting the pressure on his learners. Like, first of all, he seems really disappointed that both Samira and Giovanni don't want to be hands-on in this very rare procedure. He's channeling that disappointment into pressuring her to participate in this procedure, even when she's saying that she's physically exhausted. Doesn't really create a safe learning environment. I think if I was the attending and I hear my learner saying that they don't think it's safe for them to participate because they're physically or mentally exhausted, I definitely would not pressure them, because if something bad were to happen, that is on me. So we'll see what happens here.
Still retracting.
Any improvement?
Not really. You feeling tired?
Do we have
Okay, so
Aerogen
he's
in the
tiring
ED?
out.
Just in the unit.
Aerogen?
It has
So,
a
yes.
5mm mesh that vibrates over 120,000 times per second.
One of the toughest decisions is knowing when to pull the trigger for an intubation. And if someone is on BiPAP and they're tiring out and they're getting more sleepy, or they just can't keep up with the drive of breathing, that would be a clear indication that you need to pull the trigger and get them on a ventilator and intubate them. So what I think Dr. Robbie is doing is watching Dr. Al-Hashimi to see if she's able to discern what this evolving situation is, and that the correct decision is to pull the trigger to intubate this patient.
3 centimeters lateral.
Without any direct imaging?
Nope, straight shot into the lateral ventricle. Tried and true since 1890. Okay, go ahead with the incision.
to get a medical student to do the burr hole.
I did.
So that's the gala that they're showing.
It's not brain surgery.
Damn. Getting an MSI4 or fourth year med student to do a burr hole in the ER would be just so wild, man. I don't think this would ever happen in real life. Just not a chance.
All yours.
And just keep going?
You'll feel a pop when you pass through the ependymal lining.
And if we can get the intracranial pressure down to 20?
A third of patients like this die, half have long-term disability.
Felt a pop.
Remove the stylet.
This EVD is kind of like the plastic straw that you have in like a juice box or a Capri Sun. And the stylet is kind of like a metal trocar that actually is very rigid and guides the straw into the ventricular space. And once it's in that space, you remove the stylet and the straw, plastic straw, which is kind of like flexible, stays in there. I personally have never seen an EVD or a burr hole performed in real life. This is like totally outside of the scope of my personal practice.
I should not be sick. Kiwis before bedtime, lettuce, water, mouth taping.
What do you follow for health?
A few naturopaths and some functional healers. Kidney beans, turmeric. Turmeric?
We're starting to see people loading themselves up on turmeric like crazy. People swear by it for losing weight, for increasing strength and power, all these different beliefs that turmeric is this wonder supplement. And turmeric can actually change the color of your skin as well to orange.
How much do you take? 500 milligram capsules, but I take 5 a day.
With doses that large of turmeric, there have been cases of liver failure.
I find it unbelievable that they're not actually sending that lady with the painless jaundice for a CT scan of the abdomen. Literally, if the patient walked in with painless jaundice, they're immediately getting blood work and they're getting a CT scan. We would spend one neuron to decide. We wouldn't be kind of humming and hawing and admitting this patient for observation without doing that.
Track the online trends. I just think, what's the stupidest thing this person could have done?
Things get worse. She could need a liver transplant.
Because she's a big fan.
Santos does represent some of the people that I have encountered in the medical field. They say, oh, thank God for idiots, because this is what our job security relies on. The problem in today's society is that there's so much misinformation out there on the internet. Patients don't really know where to go for accurate and reliable medical information because so many influencers are trying to be doctors. Oh, why are doctors trying to be influencers? In order to combat all this misinformation out there, it's really important for doctors like myself and other healthcare providers to actually be present on social media, to meet people where they are getting their information and to combat all the bullshit on the internet.
Would you like to see?
I haven't looked like this in a long time.
Yeah, I don't know about you, but this case feels a little bit forced and over-dramatized. I'm having trouble buying it. I understand what they're trying to show, that ER providers are very compassionate and people that are unhoused have background stories. Like, that is true. I don't know, the way that they dramatize it isn't really convincing for me. It's not doing it for me, but anyways, moving on.
Teenager with jewelry magnets stuck to both sides of her nasal septum.
How long have they been in there? If we don't get them out quickly, it can cut off the blood supply and cause the septum to collapse.
In the nasal septum, it is a very vascular space. It's something called Kesselbeck's plexus, where there's a lot of capillary beds that actually live there. That's why when you get a nosebleed, it's usually from the actual inside of your nose and these capillaries kind of bleeding out. So if you have magnets that are actually compressing the septum from both sides, that can actually cause necrosis and for that skin to break down and severe bleeding. You can actually get a saddle deformity of your nose. I saw this a lot when the street drugs, mainly cocaine, were being contaminated or adulterated with levamisole, which is a veterinary dewormer. This would actually cause a lot of the blood supply in the nasal septum to actually get cut off when people will snort it, and that would cause septal necrosis and for that septum to collapse and for it to create like a saddle deformity. Sometimes patients' nose would actually literally fall off because it would become gangrenous. Just one of the crazy things that I've seen in my career.
Oh my God, get them off.
Yep, that's the plan.
Yeah, she tried already. It hurt like crazy because they're stuck together by a very strong magnetic force. It's still gonna hurt.
Probably not. Just hold still.
Oh, I'm guessing he's gonna dislodge it and she's gonna aspirate it. This is probably what's gonna happen. Oh, all right.
Voila.
I don't think that's realistic though. I can't really see a magnet disconnecting from another magnet and attaching to a scalpel handle that easily. Like usually it would take a significant amount of force to actually release that, but all right.
Ketamine in rock. It's time to intubate.
Hold on. No lung sliding on the right.
Pneumothorax.
Yeah.
No need to intubate.
He has a collapsed lung.
So this can sometimes happen with people that have asthma or COPD, is you can actually collapse a lung. Because the drive to breathe is so high, it can actually cause the pressure to build inside your chest wall to actually cause a tension pneumothorax, which is essentially a life-threatening condition. The first thing that we would do is perform a finger thoracostomy. So we would make a small incision, literally put our gloved finger into the chest wall to actually release that pressure, and then we would introduce a tube afterwards. That's exactly what we would do, a finger thoracostomy.
Like that.
Langdon is kind of losing it. I feel like he's made a few mistakes on this shift, missed that pneumothorax, is making some bad calls on the previous episodes as well. I'm not sure if it's just the fatigue of the shift or maybe he's rusty from being away from the ER for so long. That would be a red flag for me if one of my learners was missing all these obvious diagnoses that are time critical and important for saving a life.
You okay?
Yeah, I'm just kind of wondering if I'm really ready to be back here. Didn't even occur to me to check for pneumothorax.
Yeah, he should have caught it. Everyone has bad days in the ER. There's a lot of imposter syndrome, wondering if you were correctly selected for that role. And that's probably what Langdon is experiencing there. And I think one of the strongest predictors for job retention is having a friend at the workplace who makes you happy to go back into work.
Shit, you okay? You know what, find Ogilvy. He's just an ass kisser. He might stay and scan out the charts himself.
Oh, he scrubbed in the OR, scrubbed in on the ruptured AAA.
So, are you still going to Amy's after work? Then you need to find a new home.
Not necessarily. I mean, if I wanted, I could just check on Robbie's house once or twice a day. You know?
Why would you do that?
I don't know. Why not?
Whitaker and Santos are kind of like sibling coded. It's really helpful to have an ally in your corner when you're going through residency because it's so incredibly difficult. You just go through so many different emotional roller coasters and you're being pushed to the brink. So having other residents in your cohort or in your program that actually understand the demands of medical residency is very, very helpful. So I think it's overall a pretty cute storyline.
Where's Ogilvy?
His patient had a CT a year and a half ago that showed a 4-centimeter AAA.
Oh, damn.
It's too small for surgery. We would have seen that if the computers were working.
Yeah, that really sucks. I would feel so guilty if I was the most responsible resident or learner on this case and I didn't know that the patient had a 4-centimeter AAA. The guilt would totally eat me in that scenario. The reality is that as you're going through your training, even as an attending, there are certain things that will be missed. We try our very best not to, miss any major things, especially like a AAA. Like those are things that we would almost definitely know. But again, like in an IT outage where you don't have access to any patient records, it increases the risk of missing things. Ogilvy is a 4th-year learner and he's new to the system. The patient wasn't forthcoming with information. The IT systems were down. Ultrasound wasn't explicitly looking for a AAA. So these are all different factors that would have led to this misdiagnosis and the patient dying.
Dr. Ogilvy is just sitting out in the ambulance bay covered in blood.
He's crashing out, man. He's crashing out.
Ogilvy. You okay, man?
Damn. That gave me shivers. I got goosebumps, man. I don't know if you can see this, but yeah. Good job on the actor who plays Ogilvy, because I feel like that look on his face is something that I've seen a few times in my career, and you can just feel when someone is just riddled with guilt from missing a diagnosis. So, damn.
We do the best we can, but people die.
You ever get used to that?
No.
I don't know if I can take another day like today. Primary care specialty sounds way better.
I know I'd be bored out of my mind. Go home.
I really didn't think that I would get kind of choked up from the character of Ogilvy, but here I am. Emergency medicine is a really crazy job and not everyone is cut out for it. This discussion between Ogilvy and Whitaker is actually a good reminder for myself of how brutal it can be if you've missed a diagnosis or if you've seen one of your own patients die, it honestly, I feel like sometimes it actually does get a little bit easier just because you've seen it so many times and you are able to process the emotions a lot better. It still is quite difficult to make sense of it all. To see Ogilvy kind of struggling after such a chaotic shift and after one of his patients dies because he missed a diagnosis is something that I think a lot of healthcare professionals, including myself, can relate to. It definitely resonates. That was a powerful scene.
So now with a long-term disability, things may be easier.
Easier.
His condition will qualify him for Medicare and Medicaid, so moving forward, costs should be covered, including home health care. Just wanted to reassure you about future costs.
Damn. Bro, what's going on in the USA? Oh man, I am board certified in emergency medicine in the USA, but imagining practicing emergency medicine in the USA where you're having these critical decisions that are very sensitive with like a patient that almost died and having to talk about money in that scenario is just like, I just would hate to have to do that. I think that just that alone would just burn me out and make me hate my job.
Oh, no, I was talking about the AAA guy you worked on with Ogilvy. He didn't make it through surgery. I tried to talk to Robbie about it, but I think he's busy.
Excuse me.
Everyone's crashing out today, man.
Sign out all this shit that's bugging you and get out of here.
I can't. You're not my mother.
Yeah? Well, too bad.
Who gives a f?
I think you need a break.
I'm worried about the people that I care about.
Dude, he's crashing out too. Holy shit. Definitely needs a sabbatical, definitely needs some time away. If you're new to this channel, I would really appreciate your support by giving this video a like, commenting, and subscribing to the channel. And I'll see you in the next one. She's choking, man. Everyone's choking. Just so wild, man. Damn, this is gonna be a spicy one, I think.